Okay, so I'm going to go ahead and get started. First, I just want to say that nothing said this evening is medical advice. I am not a doctor. I'm a social work student. This is part of my semester-long focus. Please consult your doctor for anything I say, et cetera, et cetera. Also, I like to have a spirit of open-mindedness, that I might say something that you've never heard before, or it might strike you in a kind of weird way, like, wait a minute, that's not what I was taught or something. But I'm also being open-minded. So I'm here to learn from you also. So if we could just, everybody be open-minded. And when we might get mad and I might get upset, it's fine. It's totally fine, okay? And then also to be vulnerable. I'm gonna share part of my personal story. This is the first time I've ever shared it, like publicly, parts of it. So it's kind of like, I don't know how it's gonna go. So just bear with me. But I want to do that so that you guys are vulnerable on the way back, you know. All right, so who am I? My name is Angie. Like I said, these people already know me. But I'm a medically retired U.S. Army Sergeant. I'm a peer facilitator and national campaign team from Wounded Warrior Project. I'm on the Missouri Veterans Commission Innovation Task Force. I am a social work student. I graduate in less than 30 days. I'm so freaking excited. Thank you. And I'm an outpatient mental health therapist in training. So I have the clinician side and the patient side. And I'm also a VFW, Student Veterans of America Policy Fellow, and I'm 80% service-connected disabled veteran. So this, like I said, is part of my project. I did an independent study and a fellowship with VFW. So what they did was across the country, a bunch of student veterans submitted policy recommendations, and they picked 10 of us, and only 9 of us ended up making it. But basically, the whole semester we focused on whatever our policy interest was, and it was between health, benefits, or education. So I fell under the health policy. So my semester focus is on these 6 items, which some may know these terms and some may not, but as we go along the presentation, I'll explain each one. Polypharmacy is when you're on multiple medications for multiple conditions. Over-medication is when maybe you're on too many. Benzodiazepines are drugs used for anti-anxiety, so Xanax, Valium, Klonopin, Ativan. Chronic pain management, we'll be talking about opiates. Informed consent is basically like, what should you know before you take something? And suicide. So here's my story part. Okay, so I want to tell my background so that you know how I came to work on this particular issue. Basically, I was in the military for 6 years, 9 months. I was sexually assaulted, and then a year and a half later deployed to Iraq. And within 30 days, pretty quickly, I dropped down to 100 pounds. I had like bones. I looked like a skeleton. It was really bad. I had like fainting, fevers, gastrointestinal problems, nosebleeds, high blood pressure, and all the while I was still doing convoys. So like, imagine like you think you're gonna die from like some disease that you caught, and there's no medical treatment in theater, and you're getting shot at with IEDs all around you at the same time. So like, I was pretty sure I was gonna die, but I just didn't know like from what. So I lasted 6 months, and then we got a change of command, and my new commander took one look at me and said, "What are you doing here? You need medical treatment, you're gonna die." And I'm like, "Yeah, I know." So they medically evacuated me to Germany, and the very next day my convoy was hit. So then I got to see my soldier come back wounded. And basically he was in surgery. He came out 24 hours later. And as he was telling me the story, I was like, I cannot deal with one more like traumatic thing. Like, I'm done. Like, I hit my breaking point. So I saw a sign on the wall that said psychiatry, and I was taught that that's where you go for help. So I walked down the hallway, went to a psychiatrist. I said, "Hey, my convoy just got hit. I can't handle living in Germany. I think the ceiling is falling on me. Like, I'm shaking. I cannot deal with this." So the help that I received at that time was a benzodiazepine. It was Klonopin, and the guy, he's in a uniform, major, whatever. I just remember he was a major. And so like, I didn't ask questions because I'm like, this is a doctor. He's telling me this is what will help, whatever. So I took the medicine. I went on my merry way. Then what happened afterwards was I was medically retired out of the Army, and within the next 2 years, I was prescribed 17 medications at the same time. So then that included an opiate addiction. So I was doctor prescribed opiates for legitimate pain reasons. 1 pill turned into 2, turned into 7, turned into 10. At my height, I was taking 120 Vicodin a day. So I should probably be dead from that, okay? In addition to the 16 other medications that I was on. So finally I met a psychiatrist in 2006 at the VA, and he said, "Who put you on all this medicine?" And I said, well, the VA and the civilian doctors, like both of them together. And then he said, well, if I can get you a bed overnight, will you take it? And I said, sure. So they took me off like 10 medicines within 45 days. And then, so that 13-year period was 59 medications. And now I'm 3 years off of everything. But I live with neurological damage from long-term use of multiple medications. And I know I look fine, but I don't feel fine, I promise you. So that's kind of how I stumbled on this issue, was as I was coming off the medication, there was this voice inside of me that was like, who am I without all these meds? Like, I don't even know what my feelings are, what's a side effect. I just remember telling a psychiatrist, like, I don't have any good feelings. Like, I only feel anxiety or depression or sadness. Like, I don't know who am I? Like, what do I feel? I don't even know anymore. So I started just reading everything I could get my hands on, like, because I was trying to figure out, like, were the meds helping me? Were they making me worse? Like, what is happening? What did they do to my brain? I took an anatomy and physiology course. I did, like, anything I could get my hands on. I just kept reading and reading. So that is most of my story. In that time, I did struggle with suicide 3 times. I was hospitalized for that, and it all coincided with, like, medication changes. And I lost 2 friends to suicide, one of which was from a very high dose of Ambien. And so that's also a topic that I'll be talking about. So I'm going to take a zoomed out look because I know there's some very Maryville students here, and a lot of guys might not know, like, the individual statistics. But the civilian suicide rate, if you imagine 100,000 people, 11 of those 100,000 will die by suicide in the civilian community, but 30 of 100,000 will die in the veteran community. And as you know, veterans are a smaller percentage of the civilian community. Also, veterans in VA care, there has been an increase of suicide of veterans in care, which should make you think, like, why is that happening? So it's a 13% increase. But veterans outside of care are also increasing, but it's a 26% increase. So both are increasing. One is not increasing as much as the other. Missouri, this kind of really upset me. Like, in 2016, Missouri veterans, we lost 154 to suicide. That's a lot. So these are some clips I took, most of them from the last week. I don't know if you know, I think it was 3 died by suicide in the last 5 days in 2 different states. So it's definitely an issue that is, like, right now, like, what are we doing? Come on, like, what are we missing here? Because we're spending billions of dollars on suicide prevention. It's not working. So next, the topic is polypharmacy. This bag of medicine is actually from a female veteran who worked with her doctor over the course of 3 years, and this is what she had left over and dumped. So the U.S. Department of Veterans Affairs describes polypharmacy as one or more of the following. Take medications for no apparent indication, meaning, like, you might not even need them anymore. You use therapeutic equivalents to treat the same illness. So maybe you take 3 drugs for one malady. You can currently using interacting drugs, meaning, like, both of them together are probably interacting. You should take one or the other. Using additional medications solely to treat adverse reactions. So, like, for me, that showed up like my stomach really hurts from this depression medication, but instead of, like, taking that away and giving me something else, then it was like, oh, now you need a stomach medication. And now you have migraines and you need a migraine medication. And that's kind of how polypharmacy happens. So veterans who suffer from mental health challenges and aging veterans are the highest risk for the polypharmacy. But there's benefits, okay? Because most veterans have TBI, PTSD, diabetes, cancer, you know, many illnesses at the same time. So it can be beneficial, like you're treating multiple things. But there's also risks. You have a greater risk of adverse drug events, drug reactions, falls, non-compliance. That basically means, like, if you're on 18 medications, like, do you really want to take those every day? Sometimes you don't want to, so you might skip one. Or, you know, you start to lose count, like, what am I supposed to take today? There's greater healthcare utilization, which is, you know, of course, you probably have multiple illnesses, but then you are going to use it more. So early cognitive decline, mortality, and the thing that scared me the most in my research is that drugs are not studied long-term or in combination. So, like, you're basically, you don't even know what's going to happen, and they don't know what's going to happen. So polypharmacy in OIF veterans is 8.4% of Iraq and Afghanistan veterans are prescribed 5 or more central nervous system agents. That doesn't mean, like, a stomach medication. That means it acts in the brain and it affects the entire nervous system. So it's not just like a Tylenol, like it affects everything. So then I tried to narrow down the focus, okay, like, opiates is a hot issue. So let's just look at opiate polypharmacy, which, is starting to come to an end and coming down. But from 2003 to 2011, co-prescribing of benzodiazepines, that's the anti-anxiety drug, and opiates as a painkiller, increased by 50%. Okay, and then at the same time, the risk of overdose was 4 times greater when you were prescribed those two drugs together. So in 2016, I think, the FDA issued a warning not to prescribe them together. So there's been like an active nationwide de-prescribing, that's what they call it, to get people off one or the other because you shouldn't be on both. But also they found in the opiate deaths, 40% involved a benzo. So we need to be careful to call it just an opiate epidemic, because actually it's a polypharmacy epidemic, because these people had multiple drugs in their system at the same time, not just opioids. Okay, and this is a video. You're the first one seeing it. Let me see if she kind of explains the thing better than I can.
Benzodiazepines are a class of medications typically used to treat anxiety and insomnia. They include things like Xanax, Valium, Klonopin. And one of the fascinating things about benzodiazepines in the past, let's say 20 years, is that there's been a steady increase in prescribing. In fact, since about 1999, benzodiazepine prescriptions have increased about 67%, which is really an astounding number. What we've seen over that time period is a commensurate increase in opioid prescribing, but opioid prescribing peaked in 2012 and has slowly gone down since then. We've seen about a 20 to 25% decrease in opioid prescribing since 2012. However, in contrast, benzodiazepine prescribing continues to go up. There's also been a 7-fold increase in benzodiazepine-related mortality since 1999. And so what I've written about is that I really think that benzodiazepines are like the hidden epidemic. There's been all this national attention and awareness around opioids and how they can cause death and all kinds of other adverse health outcomes, including addiction. But we read very little about benzodiazepines and the fact that they are highly addictive, that they can cause death, that they cause all kinds of other adverse health outcomes. So I'm trying to raise awareness around that, especially actually in the medical community, because physicians have such little understanding of the dangers of benzodiazepines. So the way that physicians typically prescribe benzodiazepines to patients is contrary to how they are recommended to be prescribed by the FDA. Almost all benzodiazepines are recommended to be used only short-term. Now, how we define short-term is sort of in the eyes of the beholder, but generally when we're thinking short-term, we're thinking, on the order of days to weeks, not months to years. And yet we commonly see in the medical profession physicians who prescribe benzodiazepines to patients as a sort of one-way ticket. They start the prescription, the patient starts taking it, the patient endorses that they feel better, and 20 years later, they're still on that benzodiazepine, and often at a higher dose. Why? Because one of the main features of drugs like benzodiazepines is that people build up tolerance to that drug and need more and more over time to get the same effect. So we see people, who are elderly, who not only have been on benzodiazepines, since their 20s, but are now on very high doses. And we know that many of the risks related to benzodiazepines are even heightened when people get to be in their 60s, 70s, and 80s. Those are risks like fall risk, risks like dementia and cognitive dysfunction. So it's a huge problem.
So then we started looking at suicide in benzos, because now I'm like, okay, benzos are the ones that mess me up the worst, and that was the last drug I came off of. So then I'm like, okay, why did I get suicidal? I'm trying to figure this out. So I found a study that said over 200,000 veterans with PTSD were studied, and it found that veterans exposed to benzos were 3 times as likely to die by suicide. And the papers that you got at the beginning, that's kind of all my research combined together, but basically that benzo use is common. There's almost 2 million 30-day prescriptions in the VA. There's a risk for physical dependence. Now, there's a difference between dependence and addiction. Addiction means I'm craving, I'm buying from the doctor, I tell him I lost my bottle, I need a refill. You might try to buy them on the street, there's diversion. But when you're physically dependent, it's you don't have craving, you don't feel euphoria, you're just taking it like every day like a Prozac or a Tylenol or something. So that's basically what happened to me. Like I had no idea, like my brain was physically dependent on this drug because I'm just taking it every day, like whatever, you know. Then there's risk for falls and cognitive problems. I mentioned that earlier. The scary part is that in the post-traumatic stress disorder clinical practice guidelines for the VA, it says that benzos should not be prescribed to veterans with PTSD because it can worsen anxiety and insomnia. It worsens PTSD. They can't integrate like traumatic experiences because the drug like affects you in that kind of way, and increases suicide risk. And then of course you have a withdrawal syndrome as you come down. So here's some benzos by the numbers. Like I said, there's 1.8 million 30-day prescriptions. Now I don't know if that means 30 days and then 30 days and then 30 days, 30 days, or if that just means 30 days and you're done. But that's 95 million benzodiazepines in 1 year that the VA prescribed. And then this is a chart of the opiate and benzo deprescribing, so that's a good thing. The VA is definitely pulling people down. The thing that worries me is what support are they given as they come down off of one drug or the other, and are they measuring withdrawal syndromes? So here's some of the deprescribing. On the left is a taper for opiates, but as you can see, like they get you off opiates in 9 months. And if you think of somebody who's been in chronic pain for 30 years and he's on like a high dose of morphine, is 9 weeks long enough? Like, are they getting the support they need? If the veteran's on benzodiazepines, they usually take them off in 12 weeks. And it's not really like based on the symptom. And it has a recommendation at the bottom like, manage the taper schedule according to the veteran, like if they need to go slower, but I'm not sure that that's really being paid attention to. So here's the different avenues of advocacy, which is basically that each of these organizations has a legislative fellowship / team. You can get involved in your own VFW. Wounded Warrior Project has their own advocacy branch. Each one does. So I went after Wounded Warrior Project. They weren't really listening, so then I went after VFW. If I have to hit all of them, it's fine. It's fine. So here's some of the stuff that we did in Washington, D.C. I got to meet all the Missouri guys. There was like 11 guys from Missouri. But across the United States, there was people from every state. And what we did for the whole week was we went to every single congressperson in our state and lobbied to them, all the VFW legislative parties for the year. And then I was able to lobby mine. And so I had an open conversation about polypharmacy, opiates, benzos, suicide. We met Senator Roy Blunt, Jeff Smith, Tammy Baldwin from Wisconsin, and Mark Takano. I want to say something about Tammy Baldwin really quick. She had a constituent. His name was Jason Simakowski. He was a Marine Corps veteran. He was prescribed 16 medications, checked inpatient to get, he wasn't feeling good. They took him off a bunch and moved things around, and then he died in the hospital, and they did not resuscitate him. And they found out later that it was a mixture of the opiates and benzos that is what killed him. So Tammy went after opiates and made this deprescribing, but I'm like, she left out the benzo issue. So I'm working with her office trying to make some recommendations to fix that piece of legislation. Then we also got to do our elevator pitch to congressional staffers, media, and the White House policy advisor. And I'm going to tell you about that because it was really cool in a second. So here's my elevator pitch. I'm going to say it as fast as I can because I'm really hot. Okay. Hello. My name is Angie Peacock. I'm an Army veteran and Master's in Social Work student from Washington University in St. Louis. I'm here to prevent the next overprescribing epidemic like the opiate crisis, but with a different class of medications known as benzos. VA prescribing practices need to be included in the National Suicide Prevention Strategy. Benzodiazepines, also known as benzos, are prescribed for anxiety, insomnia, and chronic pain, but are not supposed to be prescribed longer than 2 to 4 weeks. Use of benzos can cause falls and cognitive problems for older veterans, double the risk for dying by suicide in veterans with PTSD, and can cause permanent disability associated with their severe withdrawal syndrome. Against clinical practice guidelines and well-known risks, clinicians continue to prescribe benzos long-term and are irresponsibly deprescribing them. I am one such case whose life has been permanently damaged from the use of benzos for PTSD. My solution is to include benzo provisions in HR 100, which I'll talk about in a second, to urge VA to redesign benzo practices by listening to patient voices who suffer from withdrawal syndromes, prevent new prescriptions, gain informed consent from patients, and slowly deprescribe when possible while allowing veterans to stay on them to reduce harm if necessary. So here's some of my solutions. Peer support, that's a big one. That's what Wounded Warrior Project guys are doing. The whole health program is the VA's attempt to shift to like acupuncture, occupational therapy, physical therapy, non-medication things that supplement the medical care they receive. To have more patient-centered care, written informed consent, research into deprescribing, support, like please just fix it. So, okay, this piece of legislation right now started with Senator McCain before he died in 2017, and it was called the Veterans Over-Medication and Suicide Prevention Act. And what they want to do is go back 5 years, it's on the next slide, but like study all these guys that are dying, what is happening, like forensically look at their life, what kind of treatment did they have or didn't they have, what medications were they on, how does the VA identify over-medication and polypharmacy, like what do they do when they see that, like they just want to look at everything. So now it's back in the House. It did not pass under McCain. So now it's with Representative Buchanan out of Florida and literally has no what do they call it? That's it, no co-sponsors. And so like I'm trying to go after that, but like why, like you've had 3 suicides in 5 days. Why isn't this passed yet? I don't understand. So here's from that. So they want to know who died by a violent death, accidental death, what age, gender, race, list medications with a black box warning. A black box warning is there a suicide risk if I take this medication? Who was not taking medication? What kind of therapy was given? What were they not given? Okay, so we're almost to the end. So this is kind of like a question to the audience. Do you think we should be more warned about risks? Should caregivers and family members know about risk? What do veterans need as far as self-responsibility? Like, how do I self-advocate for myself? Like, what do I know? Like, I know for me, I never read a pamphlet that came with a drug until this happened to me. I just didn't. I didn't question what my doctor said. I didn't ask the pharmacist. Like, I just didn't even know to do that. Treatment options. So we'd be presented with all treatment options. Like, you can do this, 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 and this, and then let me make a choice. Should I weigh the risk and benefits? And again, black box warnings, especially suicide. So here's 2 pages of references. If you don't believe anything I said, you can go read it. And then here's more information. Like I said, the VA has like an opiate decision tool about deprescribing and taper rates and support. Their benzo stuff is kind of like, it needs fixing, and then there's Intercompass Initiative and Withdrawal Project. Those are kind of like lay people that are helping each other like while they're in deprescribed because it's like such a gap in the research. And that's about it. Thank you so much for listening. Well, all right. So I just want to open it up for questions, comments. Tell me about my blind spots. Anything. Maybe even from the veterans, like your experiences, what keeps veterans out of the VA? Or how do we solve the suicide problem? Or what new ideas can we talk about? Or what can we do to bring that issue? And because the thing I was most struck by going to DC was that all the VFW guys that are there are aging, and as they age, who is going to take their spot? Like it's us. So it's like we have to get involved somehow, Anybody? Please, somebody say something.
Hi.
Hey, Angie.
Hi.
Every time I go to the VA, that seems to be the fix. It's that if someone's hurting, whatever it may be, it's here, take this. Can we get away from that? That's how we fix it.
So how do you think we would get away from that? Or what do we do?
We got to educate the docs too. I mean, and the veterans. It's like when I go and they want to give me more meds, I'm like, I don't want more meds. I'm not taking any more.
Yeah.
And I'm kind of in the same boat with you. I was active duty. They were giving me meds, but I would read the side effects, and they would say suicidal tendencies. I wouldn't take them. I'd give them back. I'm like, I'm not taking this. Mm-hmm. They're like, but it'll help you. I'm like, it could kill me.
Yeah. So you took those risks seriously.
I did.
Yeah.
I did.
Yeah.
When I got back from, I did convoys. I got back migraines, NVG. You got your phone on one ear, and your driver's telling you and looking for the helicopter, making sure we're safe. And so I get it. Yeah. I got back, and they're trying to prescribe all kinds of stuff because I was hurting. Mm-hmm. You lose people out there. Yeah. You hurt.
Yeah.
And then the first thing they say is, take this, it'll make you feel better. But I would read them, I'm like, yeah, that stuff could kill me, I'm not taking it. So I think it's educating the docs as well, and us as active military troops is, don't take everything they give us.
Yeah. Or at least
That-
read the pamphlet
That's my
before
2
you
cents.
take it. Yeah.
Yeah, just my 2 cents.
So I would piggyback and say this problem starts before we get to the VA. It starts in the military medical system, and I would say in our medical system writ large. It's
Yeah.
let's solve this with a pill, let's solve this with a drug. I think that's there.
Yeah.
So for me, in my helicopter crash and going up to launch stool, the night of my surgery, they put the halo on my head, and they come in, and the nurse has my 10 o'clock meds, and there's all these pills, and I don't take pills. I take Colon Health, I take Flintstones Complete, chewable. I've been doing that for nearly 50 years. And when she came in, I actually, what is all that? And so she listed it, and she said, this is antidepressant, blah, blah, blah. I said, whoa, whoa, whoa. I'm not taking that. I have
they
human
gave it to you
antidepressant.
without
They didn't
even-
even tell
they
me.
didn't even ask
It was
you.
just in the stack of pills.
Yeah.
And so I think there's 2 things there. One is what you were talking about, educating our medical folks, and that they should have told me they were going to do that.
Yeah.
I should have been told that, hey, we understand you've been through this horrible thing that happened. 5 people were killed, 2 worked for you, and you lived through it. So we think maybe this might help you. This is a potential option for you. If you're having trouble, we have this. They just prescribed it. The other thing we need to educate our troops and folks is to be your own advocate right from the get-go. And whatever rank you are, it's your health care. It's you. And you need to ask and take ownership of your situation. Say, what is all that?
Right.
Is this best for me? And so I think, I don't know where I would be today if I didn't ask that question that night. And believe me, I was not at the top of my game. I just had 6 screws put in my skull and a halo put in my head, dealing with everything, but I thought to ask that question. And to me, that was a very crucial moment in my recovery and where I am today. Where would I be without having asked that question and telling them, well, no, I'm not taking that. The nurses were like, okay, they weren't trying to force it on me, but that had been described, and their job was to make sure that was delivered to me. But nobody told me.
And that's that consent thing.
So there's that 2 streams of what could we do? We need to educate our military medical, and that then trickles to the VA. But then we need to tell our folks that you got to take your ownership of your own care. You can't just put it on autopilot and the doctor said, I don't care what rank you are, I don't care what rank that doctor is. You have to be able to say, hey, is that right for me? Because there are protocols and the things they do, and then there's a person. And how that person, that situation, that person is different than those protocols. By and large, it's a guide to follow, and we trust but verify. You've heard that phrase, trust but verify? I think we need to figure out how do we teach our folks to be better advocates for themselves from the beginning, from the time they enter the military, as they walk their way through their careers. And I think you do that, that will help with the VA stuff.
Thank you for that.
One thing whoa, that's way louder
That's
than hers.
loud.
One of the things I see at the VA and also civilian doctors is there's no diversification of care. That there's a huge difference between treating a patient who's 60, 70, 80 and someone who's 20 or 30. And when you go there and they prescribe something to you that has a lot different effect based on what phase of life that you're in and how long you're going to take that.
Well, I thought of that too because, like Dr. Lemke was talking about older veterans. Okay, well, we're all eventually going to be older.
Yeah.
Like, it's just a matter of time. So, like, if you put me on medication today, what is the end point?
Yeah.
Like, I never asked that question. I just took it,
Yeah, there's a lot of times I see when I go, especially at the VA, and they'll ask me my symptoms, and then usually when we hear those symptoms, it's for an older person. And it's like, well, I'm in my 30s and I have that. Like, how are you going to treat me? I have to believe that that's different for me than it is for someone that's in their 60s. Our bodies are different.
Right.
Our immune systems are different. Like, there has to be some different way to look at this than just a blanket, oh, this is the answer for everybody, because it's not. Like, and if it is it long-term going to be beneficial because I'm going to have it for 40, hopefully 50, 60 years and not just that. And also like physical therapy. A lot of times the stuff that I've seen in physical therapy is geared towards older people who have problems with arms, legs, prostates, things like that. And I'm not dealing with that. Like I just have like an issue with my shoulder here. Like I don't need the 84 different exercise. Like, so I think just diversifying that care based on the age of the patient.
Yeah. That's a good point. Thank you. Anybody else? I don't know. Yes, Deb.
Okay.
Use your command voice, ma'am.
I have a command voice, but that's what blows the microphone out. I went over for PTSD, and I was having a lot of trouble with a lot of things around the PTSD. And I got a psychiatrist lady that talked to me, and she says, well, you know, you need drugs. And I said, no, I don't know that I need drugs. I need a place to put some of my fears and anxiety, and I think I need to talk about this out loud to somebody that's not one of my friends or one of my family members. And I would like to have a place to put this. And she said, well, all I can tell you is drugs is a whole lot faster, and you'll just get over it. And I thought, that's really miraculous. How come everybody else hasn't gotten over it? And why are we talking about all this drug stuff? And I said, well, I choose not to do that. She says, well, I don't know why you would choose to take the slow route. I said, so if I take the pills, how long will I be on them? She said, the rest of your life. And I said, and now we're getting into the senior citizen point. I said, well, that's a long time. She says, well, not at your age. Now, let me tell you something.
Ouch.
My mother died at 91. My father died at 94. My grandmother died at 101. At that point, I was 60. So I had a problem with that, and I ended up coming out of care. And I still have trouble because I should have forced that issue. I may go back, but I do know that I will not be taking drugs because I do not believe drugs are the answer in most cases. But, you know, if you think they need to treat people different, you know, just because a person has hit Social Security age doesn't mean that they're at the end of their life, because they're not. At least I hope I'm not.
You got a lot of life in you. You'll be fine.
I noticed that when I go down to Florida and see my friend who goes to the VA, they have the significant other always go with them. They never go by themselves. When I go to the VA, they never ask about your significant other. They don't have any idea what medications you're on, what you're taking them for. They're not involved in the care here at all. And when I came back from Iraq, I got to tell you, I didn't know if it was day or night, where I was at, and what was going on, much less what I'm getting and why am I getting it. I
Yeah.
just know that I got a crap load of medication, and I don't know, am I supposed to take this in the morning or in the afternoon? Do I take it because of this? I didn't know. I didn't know.
Yeah.
And I got together with my physician on the outside and stopped half the medication that was on with him because I'm not taking all that stuff. I think it's ridiculous. But they don't get anybody involved. Like with him, his wife is involved with all his medication and his care. Here, unless I tell my wife, she doesn't know.
Yeah.
She has no idea.
Yeah.
And they throw you in the same ring. You know, like you're a diagnosis, you're not a person. You're a veteran with PTSD, suicidal thoughts, and that's it. No, you see, I can have a bad day and not be suicidal and not be PTSD, but have a bad day. Well, let's take this medication. No, I don't want to change. I mean, they changed so many medications, I couldn't even have told you within the first 3 years what medication I was on. I didn't know.
Yeah.
And it got to the point that my blood pressure was so high because they said, oh, you just have hypertension. But the medication I had, the interaction, causes severe hypertension crisis.
Yeah.
So they don't really know what happens when you take it.
Well,
So it's a dangerous.
and that was one of my, I forgot to add, but like, for me, when I got suicidal on my cocktail of drugs, the answer wasn't what medication is causing it. The answer was, here's another drug. So like, how do you, but that's a question in medicine. Like, I'm not going to act like I know it. I didn't know it at the time. You couldn't have told, I wouldn't have known if it was the drug doing it or me doing it. But I know that 3 years ago, when I was tapering the benzo, and I was like, I just hit, 1.5 milligrams, which sounds so tiny, but it totally fucked my life up. Excuse my language. But I'm getting lower, and I tell the doctor I'm suicidal, and he says, oh, your PTSD is getting worse. That's literally what he said to me. He said, come back in 4 weeks. So I come back in 4 weeks. I said, okay, now my suicidal thoughts are turning into suicidal urges. Like I'm having urges that I want to kill myself. And it's almost like my body is just going to do it, and I'm not going to have control over it. It was literally like my brain just broke. I don't know how to explain it. So then he said, well, I think we should add lithium for agitated depression. And I'm like, no, I'm getting off these medicines. I don't want any more, okay? So then he said, come back in 2 weeks. And I just knew, I'm not going to make it 2 weeks, dude. I'm not. Like, I'm dead. Like, that's it. And it was New Year's Eve. I told all my friends, like, I'm just letting you know I'm probably going to die. Like, I'm just telling you. And the week after that, I was standing in the kitchen and wanted to stab myself with a knife. And I was like, I'm not a knife person. Like, where the hell did that come from? I'm about to graduate from college. I don't want to die. I don't have any reason to die. So that's when I was like, wait a minute. The drug isn't working, obviously, because I wouldn't want to stab myself in my kitchen. Like, if the drug was working, that would not be happening. So I went to that was when I checked in, and they took me off the drug, cold turkey, which they're not supposed to do, and it completely fried my brain. But that's another story. So what I'm saying is, when you start getting suicidal thoughts, how does the doctor tell, is this a side effect of the medication, or is this the original? And I don't think anybody knows that. And does the veteran even know that they should be looking for that?
Right. Or why would you want to tell your doctor that you feel suicidal
And
they put you on 5 or 6 more medication?
Well, I mean, that's a whole other seminar I could do, but just like hospitalization, there's just a study like 2 days ago, I just saw it, about hospitalization increases suicide. And some could say, oh, well, the person's suicidal, that's why they went into the hospital. Yes, but like, it's an increased risk because hospitalization is not exactly a fun thing. They take your dignity, your sunlight, your friends, your family, your community connection. Like, it's not a fun thing, you know? Okay, there's somebody in the back who's been raising her hand, I'm sorry.
I can probably talk loud.
Okay, talk loud.
Well, the recording is.
Oh.
Okay. I come from an outside perspective, so I guess my curiosity would be how much of a lot of the things that y'all are suffering from and experiencing, does that have to do with the whole mentality of the mental health stigma that exists within the United States, and specifically with doctors not wanting to spend time and prescribing their patients to other mental health outlets, such as counseling, such as therapy, such as art therapy, such as all these other things that you could potentially have as a outlet, as opposed to just prescribing drugs, because the healthcare system is known for having a minimum of between 10 to 15 being a really extreme amount number for doctors to actually spend time with their patients in one sitting. And so taking that into account, I would assume that a lot of what's happening is also due to the fact that there's a huge mental health stigma within the United States, and also specifically with veterans, there isn't a lot of people focusing on this group, even though they know it's a minority group, even though they know that there's XYZ, factors that contribute to a lot of what you all are experiencing. And so I guess my big concern would be, have you seen a rise in studies about veterans? Have you seen, within the studies that you've kind of done research on, has there been an increase in awareness at all?
Well, I think, first of all, the VA is a research machine. They get billions of dollars to research, and then it's very tied to academic centers, so that as the doctor's getting trained, they will go do a internship at the VA, and they use, that's the route to become a doctor. If you ask your doctor, they're probably going to say, I did an internship at the VA. So there's a lot of research money, but this is my one, how do I say this, critique of the medical system. It's we're the experts, we know what you need, this is what you need. But veterans don't ever get a chance to do this. Just sit and talk about what is affecting us. What do we think of the treatment that we receive? What do we think of, and if they do a town hall at the VA, it becomes a shouting match, but they're not listening.
Right.
Do you know what I'm saying? They're not. Okay. So I feel the system itself is built on, we know what's best for you. You're going to do it this way. And nobody's going like this. You know what I'm saying? And then the second part I want to say is stigma. I've been thinking about stigma for years, trying to figure it out. I don't really understand it all the way, because as veterans, they have resources that they pour down our throat. Like, I can go get help from 20 organizations today if I want to. Like, I could ask Jennifer, can you give me a list of phone numbers? Because, like, I need help. And she would give me a list of 20 phone numbers. So I don't experience stigma myself. The only stigma I have experienced is one that you kind of mentioned, where the doctor is viewing me as my diagnosis. The stigma is coming from the medical professional itself. And there's actually 3 studies that I could pull right now that show, like, the diagnosis from the clinician side. That's where a lot of the stigma is coming from, especially if you have, like, borderline personality disorder, schizophrenia, schizoaffective disorder. Those people are treated differently. They just are. It's like, so that's the other thing. The third point I want to say is that the stigma, if you think about, I know you weren't here at the beginning, but I mentioned that there was 3 suicides in 5 days in 2 different states. Those guys were not experiencing stigma. They were getting help. They were going for help. The help was not working. And they killed themselves on VA property. That had nothing to do with stigma. So I would say we have to ask, where's the stigma coming from? Because for veterans, we can go to the VA anytime. I can go right now. I can take her if she needs help. So it's not like an access. I don't know. I don't know the answer. That's the whole reason I did this, because I don't know everything. I just have my own ideas. Yes?
There's a question that came to my mind. If a benzo is supposed to be for a short term or prescribed for a short duration, is the expectation that it would actually cure the person of his anxiety in that term? Probably not. So why isn't there a follow-up of a therapy or something that would address the issue without drugs for the long term? Obviously, if it's just going to get you through a month until you can get into therapy or some other intervention, obviously that's not happening in cases that we'll just use this for the next 30 years.
Yeah.
And so what has there been any studies to what should be done?
Well, I know there's some reasons why doctors prescribe them, because obviously they work. They work. It does take your anxiety away. Now, how long it takes your anxiety away until it starts kind of like you build up tolerance, you have to take more, then you start experiencing side effects. Next thing you know, you're on 10 milligrams and you should only be on 1. Like, they work, but for how long and for who? And who do they harm and who do they not harm? We don't know that. But so then there's also, like, doctors prescribe that because you have to wait 6 weeks for SSRIs to work or 6 weeks for antidepressants to work. So let's give you a benzo to tide you over until the other medication works. So, I mean, I don't know. Part of it, I think, let me think. I don't think I want to say that because it's kind of radical. Okay, forget it. I'll say it. Just that it keeps, I know I'm being radical, whatever. That like here's an example. The Missouri Veteran Commission runs nursing homes. In the nursing homes, when the old people cause trouble, they put them on antipsychotics to make them sleep. So the reason I know that is because the director of the homes program was talking to me about this problem of the Missouri Veterans Commission having to spend all this money on antipsychotics for elderly patients, and they should not have been prescribed them in the first place. Elderly, like, antipsychotics for sleep and for keeping people quiet is an off-label use. Should have never happened. So they're wasting all these. So what I'm trying to say is, like, the drug works. It keeps you quiet. Like, you're not, like, I don't know. That's radical. I feel bad I just said that. Oh, sorry. I don't know, but they work. They work.
It also keeps the cost down in the nursing home because...
Well, and benzos are cheap.
It's easier to drug somebody than it is to have, instead of one person watching that person and working with them, having 2 or 3. So it's wrong. There's nothing right about it, but that's where their motivation is, because they can't hire more people to take care of the needs.
And that's a bigger healthcare problem, that it's insurance money and how do we pay for this.
And the VA hospitals and some of the nursing homes on the civilian side have the same problem. They're doing the same thing to people.
Sorry, that's radical. Okay.
No, so the question I have is, and I've thought about this as I make my way through the VA system, still waiting on my disability rating. Is the VA overmatched by what they're being asked to do? So is there more
Good
out
point.
there that people need than
And
what
that's-
they're able to do. So there are, good people in and amongst the VA, I have no doubt.
Yeah.
But are they run over by the sheer volume of need and
Yeah.
overmatched by that?
And
And
I
so how do
forgot-
we temper, how do we look at that and go, okay, so I have this much resource, how can I best use it?
I forgot to mention that during the talk, but the White House policy advisor to the president, Trump, used to work in Senator McCain's office. So when he heard me pitching what I'm pitching, he said, "Oh my God, I wrote that legislation under McCain." And I was like, well, that's not a coincidence. But then he says to me, to all of us, because we were all pitching different things. Some guys were pitching marijuana, the burn pits, oral health. Everybody had a different issue. So he said, but you guys think that the VA can take care of everything. You have a community, you are from a city, you live in a state that has tax money. Communities need to accept responsibility for some of these problems. The VA is not going to fix everything. So that's kind of why I did this, because I was like, what can we do in St. Louis? For instance, my friend that just died 2 months ago, she was on a cocktail of medications. And she was drinking and doing cocaine and all kinds of stuff on top of it. And I'm like, look, everything you tried AA, you tried NA, you've done residential treatment, you lived in a freaking nursing home for a year. It didn't work, dude. It didn't work. And I'm like, I ain't telling you to quit everything, but the one thing you haven't tried is to just slowly taper off of everything and just maybe take less. I'm not even telling you to quit drinking. Just go less. Harm reduction approach, But how do we do that to other veterans that we see are struggling? Do we even ask that question? Do we even teach them how to self-advocate? Hey, dude, I just saw you're on 18 medications. How are you feeling? I mean, is that our place? Because everybody says oh, I'm not a doctor, I don't need to mess with that, but that's your friend. We have a suicide rate of 20 a day. We have to do something. I mean, I'm not going to just sit here anymore. So I don't know, that's the question. What do communities do? I think it's 20. It's 20. I don't know. I'm not going to argue. One or two, exactly. One is too many.
The military side is not any different than the VA is. Sorry, I'm talking a lot.
That's
But
okay.
they give Ativan, but it's for the comfort of the staff, not for the patient. See what I'm saying? That patient's being loud and disrupting the other patients, go down there and give some Ativan. No, I don't feel comfortable giving Ativan.
Yeah.
Because he's not doing anything wrong, right?
Yeah.
Because he's following you. So it's not just the VA, but we see
Everybody,
what the military kicks out, don't want to do with anymore and deal with. Then you're stuck with a system that's been broke, and then you put all these people in a system that's been broke, and then now look what we have.
Is it broken or just overwhelmed?
Overwhelmed. Well,
Perpetually-
the problem is also,
perpetually overwhelmed.
yeah, they don't even have enough employees to see everybody, but the people that they need do not exist. So they can't hire 220,000 mental health workers because they don't even exist. They're not anywhere. So that's it.
How do we figure out what,
I don't know. I'm waiting for you guys to tell me.
I'm just saying out loud, how do we
Yeah.
figure out, balance what the reality is of the ability with the
Well, and that's a question of narrative. Okay, so the narrative in the veteran community right now is ask for help. But what does that mean? Ask for what from who, and what are you going to get?
They should be offering, especially with the CODA or the OT people here, there's other things that I found that help, like kayaking, it helps. Which must be the mind.
They can't hear you. What you're about to say is important.
The question is, especially with the OTs here, there's got to be something else besides taking this medicine. Like the kayaking group, it helped me out tremendously. Before I'd work and go home, I never got involved in anything. Like speaking now, that wouldn't have happened. But there's other options. There's art. There's plant. There's fishing. There's so many different things out there to do in place of taking the drugs.
And I don't want to
switching
be
the alcohol and
Yeah.
drugs, the other illegal drugs.
Yeah, and I don't want to say, because I don't want to come off as anti-drug. Some people use them and they work for them, and that is totally fine. I'm not opposed to that. But it's just I want to know everything before I do that. Make an informed choice and think about those other things. What can I use in addition to those things, Yeah.
I have one more question.
Yeah.
If they know that we're only supposed to be on these drugs maybe a month at the max, why ain't the pharmacy saying, hey, we've been issuing out this medicine for the last 5 years to this patient. How come there's no red flag saying, hey, something's wrong here?
Yeah.
Because the bigger pharmacy likes their money.
Yeah.
Was there something on the news literally tonight about doctors that they found, right? Did you see
Oh,
that?
they were
What was
selling,
it again?
they were pulling people's teeth or something.
Yeah, there's all kinds of crazy.
What was it?
Dish out a bunch of prescriptions.
Yeah.
That just undermines the whole problem.
Yeah.
We have data.
I'd love to hear from some of the Maryville people, just like any critical thinking, thoughts, ideas,
Well,
anything.
to build off of like what she was saying, oh, okay, in the microphone, okay. I think OT can be implemented in these situations as far as like medication, because we can help people find occupations that they enjoyed before they went into like the military, and get back to those occupations and focus on something that makes them happy. And whether that's like anxiety or whatever, like helping them cope and finding different like mechanisms to help them cope instead of just like taking the pill.
Yeah.
So I think we could help in that way.
Cool.
But it's just hard to get OTs in a lot of those type of places. Like they don't. I think it's just easier to do the prescribing medications than to pay for having like clinicians that could be in there doing something a lot more like safer and healthier and yeah.
Oh.
So I don't have a whole lot of knowledge regarding the VA, but are the physicians actually suggesting other alternatives other than medication? Do they bring up other therapy or?
Sometimes like physical therapy if it's a medical issue, but
I-
in my experience, just meds.
Yeah, it was 8 years before they got me to go to eat crafts and stuff like that. 8 years. 8 years. I didn't even know it existed at the VA. 8 years.
Well, because I want to, like, if you go to the PTSD clinic at Jefferson Barracks, usually it's coordinated care. So you're going to a psychiatrist and you're going to a therapist. But does anybody like check? I don't think so. So like, if you just go to your doctor once a month and you get your refill, he's not going to make sure you're in therapy. It's kind of like a personal responsibility.
I had a client, a veteran one time, who told me that the only type of therapy that was covered under his insurance, like psychotherapy-wise, was like a group talk, and he could not do any one-on-one for like whatever. I don't know why. I don't remember why,
Yeah.
but like, and he was just like, it doesn't help me. And he was PTSD, and he was like, the stuff I need to talk about. He's like, I'm not saying group therapy wouldn't help, but he's like, right now I'm not there. I need to be
Yeah.
one-on-one. He's like, and it just wasn't helping him. And he's like, but
Yeah.
it's not covered.
Yeah.
And I'm just like, that doesn't make any sense to me. Why would that not be
Right.
covered? I just.
And maybe he had some different insurance. I don't know, because VA,
It was-
they
I
have
know it was through the
support.
VA, but I don't know if maybe he had used up so much of whatever on something else. I don't know. I just thought that was, it just
Yeah.
seemed.
Somebody in the back?
Well, and so this kind of goes back to like what I was trying to say previously, is that the mental health stigma does not come from the support that you're given. It's coming from the fact that it's easier to give you pills. And so Healthy 2020 is coming out in like another year, and one of the big things that they're claiming to do is provide more community support, provide more actual social services and community-based centers that are supposed to reach out to minority groups such as veterans.
Yeah.
And whether or not that's actually going to be the case is a different story, but like just like that mentality of here's a pill, like this will make things go faster, is so ingrained within the healthcare system
yes.
that, and like right now I'm actually doing a research paper, I'm doing my capstone on immigrants and suicide.
Wow.
And so you can, like, the parallels is exactly
It
with
is,
veterans
yeah.
as well, in the sense that there are other options, but doctors aren't pushing those options. They
Yeah.
immediately think pills because that's where the hospital gets money, that's where the middlemen between the pharmacies and the insurance companies get money. It's more so, it's the fastest route. And
Right.
so I guess, like, just again, outside perspective
Yeah.
is my frustration is that there is, and it goes back to the idea of the mental health stigma, because if we don't have these conversations, like, yes, everyone knows in general that veterans suffer from PTSD and other mental health problems, but there's nothing really truly being done about that. And that's why, like, you're having these types of events, is that you're trying to draw from your own community to create these support systems that honestly other people should be also helping out and supporting you all for it. And so I think this is like the main thing that like I've discovered within the past year as well, is that with the mental health stigma, it's not that you guys don't have support, it's you're not getting the correct support.
Yeah, that's what I think. That's such a good point, because that's why I'm saying, like, I don't know, every time there's a suicide and I see it on the news, I just get so pissed off. Like, again, and nobody knows why, and nobody knows what happened, and obviously they're doing it like as a protest almost. Like, oh yeah, I'm gonna do it here. And oh my God, I just get so upset every time. You raise your hand. Did you raise your hand? Oh, okay. Oh, him. Okay.
So, just like.
So one thing also with they're saying, these doctors aren't pushing that help. You can find ideas as well. There are many things that you can do. You don't only rely on the VA to say, oh, here's this therapy group, oh, here's this one-on-one group. No, find your own friend. Get you a dog. Ride a motorcycle. Learn to ride one.
Make tacos.
Do different kinds of practice. And there's so many different kinds of ideas that you can find yourself to help make yourself not necessarily happy again, but content.
Yeah. Good point.
Instead of pumping
Yeah.
chemicals and whatnot.
Good point.
So I'm in my 30s, veteran, deployed the same theater as a lot of my buddies. They're coming back in their 20s and they're more jacked up than I am for this reason or that reason or whatever. But, I go to the VA. The one time I go to the VA, they basically said, you must have joint pain, you have this, you have this, you have this. I kept telling them, no, this is not a chronic condition. I do not need medications for this, but this is my physical problem that I do have. And they basically said, yeah, pound sand if you don't need medication.
Yeah.
We don't care. We're not writing it down. And I've never been back for my own care. I intend to go back as an MD and say, hi guys, I'm back.
Yeah.
But
Good.
but for the guys that do need that treatment, they do need to go to the VA to be able to afford their medical care and be able to receive it. A lot of these buddies that are younger even, they're getting these pain meds, they're getting these different cocktails of meds. They've got these different problems. Some are from combat related, some of them are just medical conditions that are exacerbated by whatever that the other injuries that they've incurred. But the general consensus from the guys that I've talked to is basically, it's almost like if they're still on active duty and they refuse to take a medication or say, I don't want that medication, then essentially the doctors are saying, well, then you're not getting any more care. So
Or you're disobeying an order.
And so they don't feel like they can go back to the VA, because if they do, they're afraid that those docs are going to, they're going to incur some kind of responsibility with that and either have to take the medication or have to cease getting VA benefits at all at the VA center. So they're it forces them to go into, say, emergency room or seek different care. Is there, do you know what the current protocols or policies are regarding that?
No, but you missed the part I said, but this is kind of part of my story, that I was given 59 medications in a 13-year period. So now that I'm 3 years off meds, I'm like, why would I go to a doctor? For what? What are they going to do for me? You've already determined my pain is chronic. You got me addicted to opiates. What am I going to go to you for? There's nothing to help me. So I've basically pulled my care out of biomedical model, and I go to functional medicine. I take supplements and stuff, but as far as benefits, I'm scared to death. I could get my rating ripped from me tonight and be homeless in a month, literally, because I don't want to participate in a system that hurt me. I can't do it. I cannot do it. I hope not. Oh, I've already been called that. I've been called treatment resistant. There's all kinds of labels. They can add stigma to you, you don't, see, now you lack insight because you are really mentally ill. You need your meds, I don't know.
Remember that. I tell everybody, just take them when you get home, throw them away.
Everybody says that, but I'm so honest. Integrity is my number. So I'd rather tell you to F off to your face than take the pills and leave, Yeah, but that's my thing. If you think about this critically, if you go to an orthopedic surgeon and you tell him your leg hurts, what do you think his reply will be? I'm going to give you surgery, right? So if you go to a psychiatrist and you tell them you're sad, what do you want them to do for you? They're going to give you a medication. That is their job. They're not going to tell you a list of resources. But they're not trained in there. They're trained in psychopharmacology. That's what they're trained in.
Well, maybe they should have you see psychologists
I don't know.
When I first got introduced to the system, when I came back from Iraq, I call that Army one source, right? I mean, I was going after people on the road. I was beating the crap out of them. I was so angry at the world. I could have killed everybody if I had a gun. And they hooked me up with a lady on the outside. And I kept asking her, why am I so angry? She said, if you don't know, I don't know. I said, and they're really paying me to do this?
Oh.
That wasn't an answer. Are you serious?
Yeah.
I had no idea why I was angry.
Yeah.
Thank God for Dr. Cannon.
Dr. Cannon Dr. Cannon is the doctor that took me off 10 of the 17 drugs. He sure is. Yeah. Yeah. He said, but you know what he told me? I'm a psychiatrist who doesn't believe in psychiatry. He told me that to my face. And he took me off 10 of the 17 drugs. Yeah. 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 I would move there. I would. Yeah. So I think like 2 more questions or comments, or even if you could say you're onto something, keep going, like that would help me. Because sometimes I just feel like I'm shouting to an echo chamber and I'm crazy or whatever. So like anything you can say, we'll do 2 more and then we'll stop.
I'd like to piggyback off the astute gentleman in the rear over there with his comment about other options. There are tons of veterans organizations, more than there's ever been, and from the smallest idea to the largest veterans organization in the country. Potentially partnering with the VA or the VA part to advertise and market those, like, hey, here's options. Clearly the VA is not going to provide. Their recreational therapy has like 1 full-time person for the entire Jefferson Barracks, maybe 2. There are now. Whenever I was going to JB, it was 1. Like they're not going to tell you, hey, here's 8 other options of things you could do, equine therapy, like all these things. But hey, here's resources of these organizations, letting people know. Because I think, with the Wounded Warrior Project, most of the time I talk to people and they say, oh, I didn't know that was a thing. I didn't know I could do that. I didn't know that was available. And yes, I agree with you that we should be more, I say we as a veterans community, not myself, invested in finding those things and not just waiting for someone to hand us a pamphlet or whatever. But the reality is people aren't, and then they're killing themselves.
Yeah.
Find someone to market that, and instead of, hey, here's 8 pills or 8 different drugs, hey, here's 8 different organizations that have 8 different things you could try. Let's work on those. Work with your therapist.
But what
find
do you
out
say?
one of those.
Because I'm thinking back to like my darkest moment. You could not pull me out of my house. You just couldn't. You couldn't. I would not go to no Wounded Warrior Project thing. I don't even know who those. I would say I'm not wounded enough. Nope, I'm not going. I just don't know how to reach those guys.
Yeah. I'd say that there's definitely a bridge there.
Yeah.
They have to cross that bridge first.
Yeah.
But once they're willing to, the resources are there.
Yeah.
And let's connect you with those resources. Argumentatively, should the VA be providing those resources? That'd be great. Like, hey, these are options that don't require all this medication. That'd be great, but most likely they're not going to. They're just providing the resources. Hey, these are the things that are available. Why don't you check with these people? Why don't you contact these people? That would, I think, be a good step in the right direction to make sure people at least know that those things are out there, because people aren't checking on their own.
Yeah, go for it, Chris.
I could take a Lakota Inipi ceremony, a sweat lodge. And I have had about 7 veterans that was having issues come through. And some returned a couple more times, and some got pretty good results the first time in. When a veteran comes in, we request that they come at least 4 times to really get the full impact. And, it's not too far off. It's out in the Pacific. And, if anybody wants to be contacted when we have the next lodge, we're trying to have one in a couple of weeks. We have to watch the weather, plus the water pourer. He works a lot of weekends, so we have to work with his timing too. It is done full Lakota. It ain't no new age jive to it. It's traditional. Every sense of the word. It is traditional. It is done right. And there's no fee, but we do, there's potluck afterwards. And then if you want to donate to help care for the lodge, that's up to you. We don't ask for it. We won't take it, but it takes some money. Tarps has to be replaced, blankets has to be replaced. We do have wood parties to gather the wood for it. And all of it, every aspect of the lodge itself and the preparation of it, especially the preparation of it, because that gives time to talk freely without being in true ceremonial mode, but it all works together. And actually, there's been write-ups in the different magazines and everything. Fort Carson has one going, Fort Lewis has one going, and there's other bases that has active sweat lodges going on base. So it is a proven thing.
Thank you for that. And also, can I mention? Can you plug yourself? Yeah.
Oh, sure. I'm with Focus Marines Foundation. We do retreats 4 times a year out in Augusta.
You don't have to be a Marine, because I was
You
the
do
first
not have
Army
to be a
female to go
Marine.
through that
Yeah.
program.
I'm with Focus Marines Foundation, and we host a retreat out in Augusta 4 times a year. And we do primarily Marines, but all branches are welcome. And we do post 9/11 veterans. And we focus on giving veterans, helping them find their goals and getting out of their comfort zone so that they can start coming out of their homes and into their communities to support one another. And we do buddy checks once a month, which is a conference call, phone call. We try to just engage them on different levels on a daily basis. And the pills are a huge deal. They are taking medications they don't know what they are for. The nurses come and they're like, what is this? And is this working for me? Like, I don't know. They don't even know what they're on, so it's really sad. But my question is what if they do all the research and the act passes and they find out why all of these guys have committed suicide as the cocktails of drugs the VA has put them on? The system will collapse. Everybody will sue the VA. That's probably why it's not going through. And not
It's literally, I've never seen a bill get read and then referred to committee and just sit there, like
Yeah.
dead. And I'm like, it's been like 3 years doing that. Like, what is going on here?
Right. And the information
I don't
is
know.
needed.
Yeah, we need to know.
We need to
We need
know
to
because
know.
it needs to stop.
Yep.
Where's the dignity? I mean,
Yeah.
of all people, who else, not including me, but who deserves it more? I mean, please
I agree.
be honest with these people.
Right, I agree.
Their life is more than just throw out the medication and you'll be fine tomorrow.
Yeah.
I think
How different is it in the civilian sector? So somebody has
Well-
PTSD or somebody has a suicidal ideation.
I read like 3 studies that said polypharmacy is the rule rather than the exception in psychiatry.
It is
It's pretty
cross
common. It's common. Well, because it's like not one drug works for everybody, and everybody's genetic makeup is different, and the different theories of where that depression is coming from. Is it this or is that? Okay, let me tweak this, let me tweak that. I don't know. Yeah, it's culture-wide. Yeah. No, there's so many layers to this. There's like health literacy, what does a medication actually do? What do you expect it to do? What do you want a doctor to do for you? There's all these different, what is diagnosis? What does that do? There's all kinds of things. You don't even think like that. I didn't think like that until it happened to me. I didn't. Yeah. I want to get her first really quick. Yeah. Evidence-based. Yeah, and that's the other thing is that the drugs have evidence that they work. And then money comes from pharmaceutical companies to fund that research. If nobody's funding research for equine therapy or service dogs, then it's not considered an evidence-based treatment. The VA will not use that as a treatment for you. It's just not. So if that research is not there, it doesn't exist to medical people. Which is it. Jennifer, last one.
So I met Angie when she came to Focus. I don't even know if this is...
That's not working. Nope. Turn it back on. Oh, it is. Okay.
Okay, and I have teenage daughters. My oldest is 21 now, and one of them was struggling with suicidal thoughts, and she was on depression medicine, and then they upped her medicine, and then she was completely altered personality-wise. She was doing horrible things. Through meeting Angie, I weaned her off of this medicine, and it changed her personality crazy, but she was hospitalized twice with suicidal ideations on the medication, and not once since she's gotten off and started smoking pot, which, I'm not an advocate for that, but it's working for her. But my 13-year-old daughter is struggling with stuff, and I took her to a therapist, a talk therapist, who suggested I take her to a psychiatrist and get her on antidepressant medicine. I'm like, absolutely not. I'm coming to you to avoid this process. So that was her first suggestion as well, which I was baffled. And
I say whenever, because I'm a therapist in training, but when a therapist says that, that means like, I don't know how to help you. So that means she fired herself, so move on to another one. But anyway. Yeah. Because teenage girls are scary. I mean, that's a lot. It's scary. They're scary. I know I was scary. Woo! Okay. Anyway. Yeah. You got 3 of them coming too. Oh my God. Oh, and then I just want to plug one more thing. The Kaufman Fund created a mental health collaborative between Jewish Family Services, Lutheran, Catholic. So now if you want an option outside of VA for counseling, call the Kaufman Fund. They will intake you. It's very quick. Right now, like the caseload is like empty and we're just waiting for people to come. So if you need a therapist, that is not a problem. That's it. All right. Well, thank you so much for coming. Thank you, thank you, thank you. Thank you. Thank you. Thank you.